Hello, everyone. I'm Dr. Rahman Chung, and this is Jessica Tolentino. We're excited for everyone to join us today on Vertigo and Dizziness, the Unseen Struggles. And I'm going to just jump into this presentation. And so please save your questions to the end, and then we'll be able to do a Q&A at the end and answer all of your questions. But also feel free to type in your questions in the chat, and so we can make sure we cover them if we don't cover them in the presentation itself. Okay? All right. I'm going to share my screen here. Okay. So vertigo and dizziness. I'm going to pin myself here. Okay. All right, just a little bit of background on myself. My name is Dr. Rahman Chung. I've been in practice for 18 years and been a specialist in functional neurology, or what we call chiropractic neurology as well. I started my practice here in San Francisco 18 years ago, and it really all started in healthcare with my background in skateboarding. I was a sponsored amateur. I was supposed to go pro at 17 years old until I ended up getting recurrent injuries that led me to question the longevity of the sport and start getting treatment with alternative medicine from chiropractic and acupuncture, massage therapy, other kind of somatic awareness kind of practices like Feldenkrais. And then I decided to quit skateboarding. And my first year in college in Montana, I woke up in the hospital following a concussion and dislocated shoulder. And from then on, I knew I was going to go explore the career of alternative medicine. I enrolled in an herbology program and back into college through for environmental sciences, where I can identify plants and learn about the environment and identify herbs and make tinctures and salves and all of these things and kind of learn about the environment and health in that way. I also trained with a English osteopath in cranial fluid dynamics and applied ontological kinesiology, about more of like a spiritual biopsychosocial model to help understand where our pain and emotions and behavior come from, and a variety of other integrated therapies for therapeutic resolution and from a whole mind-body approach. I then got into chiropractic college and discovered chiropractic neurology and did that entire training while going through chiropractic college and all the other subspecialties that the neurology programs offer, from concussion to dizziness syndromes to movement disorders to then also neurotherapy and neurofeedback aspects, and doing what I do today, which I love. I'm going to pass it to Dr. Tolentino to give her a little bio.
Thank you for that. So my name is Dr. Jessica Tolentino, and I originally got my introduction into, brain and body health. I started studying psychobiology at UCLA for my undergrad, and I was introduced to the field of QEEG and neurofeedback. So we're going to go into those things later. But it was essentially, I was given the idea and the concept that when given the correct tools, the brain and the body are meant to thrive, meant to be healthy, meant to heal. And that was a really empowering thought. And learned that, with the correct technologies and the correct application of certain ideas and principles, that there's really so much that we can do in terms of being empowered to heal our bodies and our brains. So I've focused on learning techniques to help rehabilitate brain from brain injuries, but a lot of these techniques can be applied to other neurological conditions. So that includes dizziness. So just been really excited at the idea of bringing access to this information and to these tools to people who are suffering, and really empowering people to know that there are solutions for them out there if we just, you know, provide the right education and resources. So.
Excellent. All right. So our mission at NeurAccess Health, our company here, is to really transform lives through personalized neurotherapy and rehabilitation. And our agenda for today is to review really all of the most common causes of vertigo and dizziness, and a case study or two, and our evaluation and treatment approaches. So let's talk about vertigo. Vertigo is really defined as a sensation of spinning or motion. Most people feel like they're spinning in a circle, may get up one morning and feel like they're spinning out of control, having a difficulty balance, and maybe even nausea or vomiting. But usually someone perceives the world or themselves spinning. It's a symptom and not a disease, and it's often caused by the inner ear or something in the inner ear, or but also in some other cases, the central pathways of the brain processing equilibrium centers related to the eyes, ears, or balance systems. So peripheral vertigo, peripheral means coming from the ear. And we have an image here on the right that you have your ear canal, your ear drum, and then we have the middle ear in pink, this section here, where we have these little bony ossicles that kind of operate as like a drumming system for translating vibrations of sound into auditory signals. And then this little blue snail-like structure is the vestibular system. These little semicircular canals, which are three of them in here, allow you to sense and perceive movement of the head in all three dimensions. You have two pairs of these, one in the right ear and one in the left. And so these are your brain's compass, their equilibrium centers. When you turn your head, this little fluid system activates these hair cells and reflexively move your eyes and fire down through your spine and body to stabilize your posture and balance. So these are, we can generally refer to as the equilibrium centers, inner ear or vestibular system. This little other portion of the snail is the cochlea, where you have your hearing apparatus as well. So oftentimes you can have an issue, and this semicircular canals are considered the inner ear. And so the most common cause of vertigo, acute vertigo, is when you have a little crystal called otoconia that sits in this middle area called the vestibule, or kind of waiting room, if you will, and it dislodges and slides into one of these canals. Oftentimes it happens when you're sleeping and it slides one to the that's kind of located into the back towards back portion of the inner ear. And as it falls back there, when you wake up and try to sit up or turn, now this crystal is floating through this canal that detects head motion or spinning, and now it's causing vertigo just when you're trying to sit or turn. And then the crystal settles down, and then the vertigo stops after a few seconds or a minute. So that's called benign positional paroxysmal vertigo. They call it benign because nothing bad is really happening medically like a stroke. It's just a crystal, but the symptoms are quite severe. And sometimes if it's their first time having it, you end up might going into the emergency room to make sure it's not a stroke and being diagnosed with this properly. But oftentimes people don't have the right technology to identify exactly what it is in the emergency room, so they'll come to places like our office. What you'll also see in this diagram here, connected to the blue snail, the vestibula and the cochlea, is this yellow structure here called the vestibular cochlear nerve. Now, this is the nerve that communicates the information from the inner ear to the brainstem. Now, you can also have viruses that affect this nerve and can abruptly turn it off. And so that is the second most common cause of acute vertigo. And this is called vestibular neuritis, which inflammation of the vestibular nerve. And this is abruptly turns off. So all of a sudden, the balance between both inner ears related to head motion and turning are completely asymmetric. And the good intact side that's not affected is still working, but it's now causing you to sense like you're spinning out of control as well. And there's a big difference between what that feels like versus the crystal version of BPPV, which is just positionally triggered. The vestibular neuritis is constant because it's just something that's turned off. So you're having constant sensation of vertigo that's not really going away if you're sitting still. And that's the most common cause. Most people need to have prednisone to help decrease the inflammation and protect the nerve from being damaged. Other things can also happen in the inner ear that create what we call Meniere's disease, where we get pressure buildup in the inner ear, affecting pressure changes of these canals, leading to transient vertigo. That would be called Meniere's disease. You can also get little perforations into these little membranes here between the middle ear and the inner ear, and that's called a fistula. And that you would have like pressure changes, coughing or sneezing, triggering brief episodes of vertigo or spinning. So as you can see with each structure, understanding the structures allows us to understand like, oh, this is why you can have slight differences of vertigo and dizziness with depending on what part of the inner ear is affected. You can have more serious things also like tumors that can compress on this vestibular cochlear nerve, and that would actually involve dizziness, vertigo, and oftentimes hearing loss as well. And that's usually slowly progressive over time since a tumor slowly grows. And there's a variety of other things like herpes that can affect the nerve and also cause like a Bell's palsy or facial weakness at the same time as it affects the facial nerve. So all of these different structures can cause different kinds of dizziness. And so it's important to be able to differentiate what those are. So then we have central vertigo. Central vertigo is now it's not happening from the inner ear. It's happening from the central pathways of the brain stem or brain that are communicating information from your balance system or your muscles and joints in your body, communicating from the inner ear or your visual system or perceptual areas of vision and balance. And any disruption of these pathways from different illness or injury can cause vertigo or dizziness. Now, the most common ones can either be from a vascular issue like a stroke. These can be just a transient effect where you're getting happening for hours or so that lead to an emergency room, but then they improve and completely go away. Or it can be actually from a stroke, like some kind of clot that gets disrupted through a blood vessel into these balance systems of the brainstem or balance on the bottom of the brain, and then cause vertigo, but usually a whole other constellation of symptoms like unsteady on your feet, can't touch the finger to nose or hold the eyes steady. So there are other signs and symptoms related to just pure vertigo that people are experiencing when they're affecting these central pathways of the brain. Other non-vascular causes aside from stroke and these attacks are things like vestibular migraines or what we call triple PD, which we'll go into more detail, epilepsy when you affect the temporal lobe, it integrates vision and balance, and MS and a variety of other things. But this slide is really to illustrate we have a difference of peripheral causes and central causes of vertigo. So we're talking about vertigo, spinning, and not dizziness. We were just talking about the three most common causes of vertigo, peripheral vertigo. And these listed out here are benign paroxysmal positional vertigo that I was describing about the crystal being dislodged in the inner ear. And we have vestibular neuritis when the nerve gets affected, or Meniere's disease related to pressure changes in those inner ear chambers or vestibular system related to movement of the head. You'll see that they're all acute onset. They happen all of a sudden, and the symptoms are quite significant of spinning. And then when you look on the second row down, we have how long these symptoms last. In BPPV and vestibular neuritis, the BPPV is short duration, just usually seconds to a minute, and then you're sitting still, the symptoms are stabilized. In vestibular neuritis, like I mentioned, they're more continuous, and also the recovery is longer because it takes longer time for that nerve to recover versus just dealing with a crystal that might just self-resolve over time or within days or a week. And then we have Meniere's, which is more related to pressure and inflammatory changes in the ear. And this can fluctuate more because inflammation and pressure can change from day to day or throughout the day, related to allergies or related to a variety of triggers related to pressure. And so that has more of an intermediate duration. So these symptoms and with BPPV are usually seconds to minutes. Vestibular neuritis is more constant. And then, like I said, with Meniere's, it fluctuates throughout the day. Now, this also is different with what triggers or makes these symptoms worse in each of these conditions. With BPPV, like I mentioned, it's just a crystal floating that shouldn't be where it is. So every time that you change position or lie down or roll over in bed or sit up, then that will cause the crystal to move and trigger the vertigo. Vestibular neuritis, there's a communication problem with that nerve. So those symptoms are constant and work, but still worsen with head and body movement because there's an asymmetry of the information between both inner ears and head motion. And then with the Meniere's related to the pressure changes, they fluctuate and worsen with still head and body movement because there's still a disruption in sensory processing, but there can also be things like head pressure and things like that. And sometimes coughing and sneezing can make it a little bit worse. So this is another slide related to short, intermediate, and long duration of vertigo from the inner ear. You can see the rows on the left, we have more conditions that can cause vertigo. And you have the BPPV, as I described, and then you have superior canal dehiscence, which means that you have a crack in the temporal bone that's the covering of that inner ear, and that can happen from head injuries or other mechanisms. And then you can have changes in blood flow, and you can have medication changes, and you can also have changes of the structure related to the balance system called Chiari malformation. Um, so that's all on that left side. These are short duration of symptoms. They happen very briefly and resolve. Now we have the column in the middle. These are ones that are intermediate, like migraines or kind of nutritional or blood sugar or hormonal changes called metabolic disorders. The Meniere's disease and infections and panic attacks, these are all can relate to hours or days. And then we have the longer duration ones that take longer to recover or can be more chronic, like head injuries and the vestibular neuritis if it doesn't fully recover, or stroke if you don't fully recover, and some medications and things like infections that affect both the inner ear and hearing called labyrinthitis. So there's a whole range of disorders. As a clinician, we're taking a good history to be able to differentiate the time course of the onset of these and the historic nature of maybe you've been having some of these symptoms fluctuating on and off for years to the point where it is now. So with dizziness, now we're not talking about spinning or vertigo anymore. We're talking about a broad generalized term that can mean different things to different people, but it incorporates a variety of sensations involving such as a sensation of swimming, feeling lightheaded, feeling foggy, maybe a little spinning or wobbling, rocking like as if on a boat, weakness of the body or legs, or just unsteadiness. Sometimes people feel it more in the head versus sometimes feel it more in the body as far as a weakness or unsteadiness. So it's a range of different descriptors depending on each person. What's important is that dizziness is extremely common. It's one of the third most common complaints for people visiting their primary care physician, and it shares equal time with both headaches and back pain. And 50% of people complaining with dizziness to their primary care physician don't receive a diagnosis. And unfortunately, 70% of those people complaining of dizziness receive a prescription of meclizine, which is a type of antihistamine that helps with acute vertigo, but it's only good for those episodes related to like BPPV or vestibular neuritis, only for a few days when the symptoms are at its worst, so someone can be a little functional as they get the right treatment for it. But it's an inappropriate prescription or treatment if it's used for other types of dizziness because it prevents the vestibular system and the rest of the brain from adapting to what's happening and restoring from other rehab or exercises. It prevents that adaptation. So that's important of why it's very important to have a proper diagnosis and be able to be evaluated sooner than later. Now, the central pathways that I described related to the dizziness syndromes are related to three primary sensory systems: your eyes, your ears, and your muscles and joints. So you have your visual system, you have your vestibular system, and then you have your somatosensory systems, which is just input from the body: eyes, ears, muscles, and joints. These are integrated into the brain for your sense of balance, awareness, and orientation. These are the pathways looking from the side of the brain. So you can appreciate how they're distributed. And just like we were talking about the central and peripheral and central pathways, now you can see the central and peripheral pathways. We have the vestibular system outside here to the left and the cochlea. And then you see it connect to the brainstem here through that vestibular nerve, connecting to these other nuclei or cell structures that process the vestibular system. And then we have your cerebellum here at the bottom of the brain. This is the part of the brain. Some people just generally refer to it as the balance system, but that's really the cerebellum and the inner ear together. But the cerebellum primarily, one of the most important functions is it receives all input from muscles and joints. So all that info from muscles and joints is coming up through the spinal cord and going into this cerebellum, interacting with the vestibular system to help control sense of motion and balance. And then it reflexively moves your eyes so you're orienting to where you're going. So from the eyes down, these are reflexive systems that don't take conscious control. They're just working there for you. And that's great until they don't work. And then from there, they're going up through these other relay stations up to the top of the brain where you have perception and voluntary control. So now you have visual and spatial perception and then motor control with now what you can see and what you want to do. So these whole systems from the bottom up and from the top down of the brain are your central pathways for balance and orientation. The three most common causes of dizziness are vestibular migraine, chronic subjective dizziness, and persistent postural perceptual dizziness. Now, vestibular migraine on the left here is a very common one. Now, most people have sometimes a slowly progressive history. Some people have maybe already have a history of migraines, but now those episodes change into the dizzy type of migraines. Now, what a lot of people get confused about vestibular migraines is that you think you need a headache like a migraine, but you don't. Vestibular migraine is really just referring to that it's coming from the central pathways of the brain that I just described. And these systems of vision, vestibular, and the balance systems are hypersensitive to visual movements or balance, but they're very episodic like a regular migraine. They can be triggered and then you have acute vertigo lasting for days, a long intermediate time course. And you feel like you're imbalanced or spinning for hours or days, and then gradually get better and are symptom free from then on. But the triggers still might be like bright lights or visual movement or stress or a variety of other things, kind of have similarities with the classic migraine, but the symptoms vary a lot depending on which system is affected the most. The chronic subjective dizziness is, what's important is that you have more of like a visual motion sensitivity and sense of dizziness. It's not a vertigo sensation at all. There's a high association with anxiety or just visual motion sensitivity with these cases. You might feel unsteady and they can be triggered by a variety of things, like anxiety. It can be following a head injury or other changes in blood flow, um, is all other common findings. Persistent postural perceptual dizziness is similar to chronic subjective dizziness, but often is triggered or starts with an acute event related to the inner ear. So it could be start with a vertigo disorder like vestibular neuritis or BPPV, but for some reason it perpetuates. Instead of recovering, now this change in sensory input from an acute event now has led to converted to chronic symptoms. So that's one type of mechanism. But it's very heterogeneous with triple PD because there can be other issues related to these structural pathways in the brain, and also can be triggered by a severe stressful event that has led to kind of sticking with hypersensitivity to visual motion. But it's really more about a mismatch between your sensory systems, about visual processing, about inner ear motion of the head, and about input from the body. There's a mismatch of how this information is occurring. Most of the time, the visual component is very sensitive, because that's more exacerbated or heightened by our sense of stress in the visual world because we're trying to anticipate what's happening. But the feedback from the body and gravity is slower, or there's an imbalance in processing in some way. So there's a lot of similarities of these, but what happens as we go through the diagnostic process allows us to differentiate. And some of the biggest factors is related to, if we're looking at the bottom portion, is the diagnosis. The diagnosis of vestibular migraine is mostly through the history. And the diagnostic test that we'll go through is really ruling out saying, okay, there isn't, for most of these cases, any issues with the vision or vestibular system. With that being said, up to 30% of people with vestibular migraine may have an inner ear weakness that we can identify and respond to vestibular rehabilitation. The chronic subjective dizziness, if this is true, um, all exam findings, whether it's all the vision and vestibular testing, MRIs, these are all normal. Even the examination from a neurological perspective is normal. When we're talking about triple PD, now when we're looking at the exam findings, like I said before, it's very heterogeneous, meaning that we may see issues with eye tracking. We may identify issues with inner ear and vestibular function, and may even find structural changes related to these pathways in the brain with an MRI. And now that's a lot of different options, right? So how do we determine that is really based off of the history, the time course, and the diagnostic testing so that we can get to the right diagnosis and the most appropriate treatments. So again, this is a slide of just continuing what I just referred to. We want to do all basically the same tests for each of these conditions so that we can differentiate what are you going to be a good best responder for, whether medication, rehabilitation, or other forms of neurotherapy. So with post-concussive dizziness, this is one of my favorite ones because we just covered the peripheral and central mechanisms of dizziness and vertigo. Now, when we're talking about injuries to the head and brain, all things are up for grabs. You can have almost anything happen. You know, these are very significant types of trauma that can affect the inner ear or the central pathways of the brain. And so you can get one or several causes of vertigo and dizziness. So if we're looking at the causes on the left, we already covered the BBPV. You can, from the head trauma, can dislodge a crystal in the inner ear. On top of that, there might be inflammation or damage or swelling or kind of blood that gets inside that whole vestibular and cochlear apparatus that looked like a snail and cause damage to that structure itself, causing vertigo and hearing loss. You can trigger a vestibular migraine related to the head trauma and brain injury, or you could have disruptions to any of those central pathways in the brain related to tissue damage or other factors of like torsion or inflammation, all related to the trauma to those brain regions. And then you have psychological factors, whether that's from the brain injury or the history of having, like, for example, anxiety or ADHD before a concussion, and then you have a concussion on top of this. Now you have areas related to your thinking and planning and attention that make it hard to adapt to these new injuries, triggering dizziness, further perpetuating the symptoms and leading to a prolonged recovery. So almost all things are up for grab when it comes to concussion. So why now you understand why it's so important to know the different possible mechanisms that cause dizziness and vertigo. Many people will present with a recent head injury and concussion. They're complaining of vertigo and imbalance and all sorts of things. And I can identify that there's a BPPV mechanism in the inner ear, treat that right away, and have a large portion of their symptoms resolve within either minutes or a day or two, and then see what else is left as far as concussion to address. When we're talking about those central pathways of the brain, one of the most commonly undiagnosed injuries is diffuse axonal injury. And this, what that means is related to the structural areas related to what we call gray matter and white matter. The gray matter is on the surface of the brain where we do all the perceptual and interpretive work of what we sense and perceive. And then that communicates to what we call the white matter, which are the axons. They're part of the wiring, if you will, connecting the cell bodies on this gray matter part of the brain to the next component or relay station. So these are white matter tracks like wires that communicating information to all these different brain regions. And when you have a head injury, that shearing mechanism or torsion causes a disruption between where those two connect. And that's called an axonal injury. These are often missed because MRI is often not sensitive enough to detect small tears So you might see little tiny spots on an MRI, or if you have a more significant, moderate head injury that's more structural damage identified, you can identify these more easily. But one of the things that we use in our office is a brainwave analysis that can more sensitively detect injuring and shearing forces affecting these pathways, leading to more appropriate diagnosis and understanding why people are having chronic post-concussive symptoms. So this is just to illustrate, you have lots of lobes of the brain that do different functions. When you hit your head and get a brain injury, you can affect lots of different areas related to vision or hearing or sensation or cognitive functions. And so understanding these allows us to differentiate what brain regions have been affected and what kind of treatments to do. So with long COVID and dizziness, it's kind of similar to concussion in a sense that still the same principles apply, that the central pathways of the brain can be affected related to vision, vestibular, and processing input from the body, but you have slightly different or more triggers of what is causing symptoms and affecting the brain. So on the left column, we have inflammatory triggers that can either cause inflammation in brain structures or cause inflammation in the blood vessels, and kind of similar to having a migraine or a headache, but it's triggered by a virus causing vascular inflammation and affecting the brain and regions related to sensory processing and causing dizziness. Then you can have changes of blood flow and blood pressure that are all involved in that kind of vascular inflammation. And then, or regulation from your heart and lungs. You can have your immune system creating these large reactions to try to deal with the virus, causing an inflammatory cascade affecting the brain in these pathways. You can have reactivation from having COVID of pre-existing viruses that you've already adapted to in some sense, like Epstein-Barr virus or mono, can reactivate in the immune system or body, and then contributing to more fatigue and cardiovascular fatigue and also brain fog and dizziness as well. And then we have what we call dysautonomia, which is irregular control of heart rate and blood pressure to changes of position or activity. And these can just really prevent you from being able to be active and on your feet. So all of these mechanisms can be caused by COVID. And again, we still want to do the same process with evaluating each of the different sensory and cognitive systems, but then also usually work collaboratively with somebody who can do other kind of holistic aspects affecting inflammation, antiviral control, or other immune modulated therapies and treatments so that we can have a more comprehensive approach to improving the brain with neurotherapy and rehab, and also working on underlying mechanisms related to the virus, inflammation, and various mechanisms. So other types of non-vestibular dizziness. The list keeps on going on, doesn't it? So I'm not going to go into great detail on all of these because they'll make quite a bit of sense when you just see them. You obviously can have things like high blood pressure or low blood pressure that affect blood flow to the brain and can cause dizziness. Similar to that, you can have dehydration that affects your blood volume to your brain, and that can cause you lightheaded or dizzy as well. You can have hormonal changes or low blood pressure or thyroid imbalances that can make you feel fatigue and lightheaded and brain fogged. You can have other kinds of illness or infections that can, of course, affect how you feel and think, and with brain fog and dizziness. And a whole host of medication, prescription, or recreational drugs that can be a side effect causing dizziness. And many of these are known, a lot of most common medications are known to cause dizziness, like antihypertensives for high blood pressure, or diuretics, or antivirals, or antidepressants. These are known to commonly cause dizziness. So it's important to communicate with your prescribing physician if you recently changed or went on a medication, you might be having a reaction. And again, we're talking about time course for medications. Some of them are short acting, but a lot of them are longer acting, so causing more chronic symptoms as well. But paying attention to your history and what you've been doing is important. And of course, allergies as well can cause congestion or trigger the inner ear pressures called Meniere's disease as well, especially in the springtime. These are all other contributing factors of dizziness that are not directly from the inner ear, but may affect it or affect other blood flow and metabolism that affects brain. So I'm going to have Dr. Tolentino take it from here for going into the evaluations.
Great, thank you. So, as Dr. Chung went through, there are so many different causes um, for dizziness and vertigo. So, it's really important to have kind of a good method for evaluating all of the potential systems and routes for these symptoms. So, when you're doing evaluation, our approach is to be very comprehensive, looking at all of the different, sensory systems that contribute to a sensation of motion, vertigo, or dizziness. So just to kind of go through, so I like to kind of think of with dizziness or any other kind of set of conditions. Um, when we're dealing with neurology, I like separating things into it's like we're evaluating the hardware and we're evaluating the software. So when we're evaluating, what I say, the hardware, we're looking at the different sensory organs, the things that take in that type of information and making sure that they're functioning. And then we want to look at the software. So we want to look at the brain itself and look at how it's integrating that kind of information, if it's doing so appropriately and properly, or if it's having a hard time and now it's giving you symptoms. So in order to do this, we can start with the quantitative EEG. So this is to look at the brain itself, so the software, and see how the brain, those higher central pathways that are involved in processing motion, vision, vestibular input, proprioception, see how those processing centers are doing. Are they functioning properly? Are the regions communicating properly, or is there a breakdown in function or injury to those areas? So we can see this all reflected in brain waves in the QEEG. Then we want to also look at downstream the sensory aspects. So we like to look at I'm going to come back to neurocognitive testing, but we like to look at video oculography and video nystagmography. So this is really when it comes to dizziness, the gold standard for assessing and evaluating the peripheral nervous system. So looking at the eye movements and how they are related to the vestibular system, these reflexive eye movements. And we look at, how is the inner ear functioning? Are there asymmetries from side to side reflected in eye movements and a sensation of spinning or dizziness? We can also do positional testing with the video oculography so we can actually see what the eyes are doing in response to positional changes that are causing dizziness. So we can use that to, for example, identify, is it BPPV? If it is BPPV, which canal is being affected? Because a lot of times, if you go to either emergency room or urgent care, they might diagnose BPPV, but they may not know which canal is being affected, and they may not be able to give the appropriate maneuver to get that crystal into a neutral position to stop the dizziness. So it's really important to be able to identify which specific canal is being affected, and we do that using positional tests and video oculography. We can also see specific eye movements related to, for example, if it's vestibular neuritis, we'll always see a very consistent eye movement reflective of what's happening in the inner ear using video oculography and video nystagmography. So this is really the gold standard for being able to differentiate the different types of dizziness and then to be able to give the appropriate treatment. And then we like to do other testing related to the somatosensory system, which is really integral in our proprioceptive system. So remember, Dr. Chung went over the different systems that make up the balance system. So the eyes, the vestibular system or the inner ear, and then the proprioceptive system. So this is when we're looking at are the muscles, the joints, how are they giving information to the brain, and how is the brain processing that information? And is it doing so appropriately? And then we can also do autonomic testing to look at different mechanisms related to blood flow, blood pressure, things like that. Because as we saw in that comprehensive list, one of the things that can cause dizziness is related to blood pressure, for example. And there can be issues related to the heart itself, but there are also different pathways in the brain that can control blood pressure. And so like to look at both of these things to see how that's contributing to dizziness or if it is. And then physiology, if there's from the other the last list Dr. Chung went through all of those different factors related to metabolism, looking at things like anemia, looking at vitamin deficiencies. These are all things that we need to rule out if we can't get to the source of the dizziness. So we like to make sure it's very common for people, for example, to have an anemia and not realize that that is what's causing their dizziness. So by taking this comprehensive approach, we're able to leave no stone unturned and really get to the root of the dizziness. And it's important to get to the root so that we can give the appropriate treatment, because otherwise, if you give a blanket approach to treatment, you're really not going to get most of the root cause. So we're just going to go over each individual type of testing just kind of quickly, but this is really the main slide to take away information. So this is just a slide to illustrate quantitative EEG. So this is that measuring of an evaluation of the actual brain itself reflected in brainwaves. So brain is an electrical chemical organ. It works by the cells sending little electrical signals to communicate different kinds of information. And that electricity can be measured at the scalp by putting a cap on with some electrodes that just measures the electrical content. We know that the brain, when engaged in certain, for example, at rest, we know that the brain should be producing a specific kind of electrical activity. And if we see deviations from that, we know that maybe there is an issue with function in a particular region that is not doing what we expect. So we might see areas that are overactive, underactive, or not communicating properly. And if we see that dysregulation happening in those centers that are related to processing visual or motion or proprioceptive information, then that could tell us that, okay, this person's brain is struggling, and that might be why they're causing it's causing a symptom of dizziness. So this is particularly important when diagnosing things like vestibular migraine, because a lot of the physical exam findings will be normal, more or less. So it's really the QEG that is really instrumental in identifying those areas of weakness in those central pathways related to the dizziness, and then coming up with ways to address those areas. So this is just a little information about what EEG is, how the cortical cells, so the topmost layer of the brain is what's producing these electrical measurements, and all of the different kind of information that can be reflected in those measurements. Typically, historically, it's been used to identify epilepsy and seizure, but it can be used for so many other things related to that list there and all the things that we've discussed so far. And this is just a picture, so if you ever come into the office, you'll see just wear a cap, and we put some electrical conductive gel, and we measure two recordings, 10 minutes eyes closed, 10 minutes eyes open, just passively recording. It's very easy, very straightforward. It's not invasive. It's not having to sit in an MRI for an hour. It's relatively easy compared to any other types of brain imaging techniques. And this is just a slide to reflect the different types of electrical content that we can pick up from the EEG and the QEEG and the different meanings. So like I said, we can have high levels of fast activity, slow activity. We should be able to see a, a relatively predictable amount of each in a resting state. And so when we see deviations, these are different things that could mean. So I'll just go on to the next slide. So in the QEEG, like I said, there are different patterns of activity that we expect to see. And if we see deviations from that, that might mean symptoms. And there are certain biomarkers for where if we see, for example, an excess of beta in a certain area, that is related to anxiety, like most likely, or OCD. And there are different biomarkers for different conditions and symptomology that are reflected in the brainwaves. And this list is by no means exhaustive, but it's just to illustrate that, there are specific things that we can see. And when we see that, all right, that's a biomarker related to this specific symptom. So we can address that and identify that specifically. And then another test we like to go over is related to cognition, so neurocognitive assessment. A lot of times if people have been dealing with chronic dizziness syndromes for a long time, it can affect downstream their cognition. So we like to assess everyone's cognition, the different cognitive domains. Having a strong vestibular system, for example, is highly predictive of cognitive abilities. So when we see deficits in cognition after maybe, long-term chronic dizziness or vestibular issues, sometimes that can be reflected in these kinds of tests. So we like to assess those as well. So this just compares those cognitive domains to a normed average, so we can see where main deviations are, just to see how everyone's cognition is doing, and is it changing or improving with time, or is it worsening with time? So it's really good to get that baseline. So here's an image of that video oculography or video nystagmography. This is that gold standard for diagnosing dizziness issues. So put those goggles on and measure the eye movements in the dark to see the reflexive eye movements that are related to the inner ear. So this is looking at a reflex called the VOR, the video, or the so it's looking at the VOR, which is a reflex. So if I'm turning, for example, trying to keep my eyes steady on a target, my eyes will turn at an equal and opposite rate as my head is turning. And this isn't something that I'm doing with intention. This is a reflex. So when we see certain reflexive eye movements that shouldn't be there when our eyes are just in the dark, that tells us a lot of information about what's going on in the inner ear itself. We can do further testing as well. On the right, you see this is a machine that does air caloric testing. So this is really looking at if there are major asymmetries between left and right inner ear or vestibular system. And then this is the computerized posturography. So this is looking at people's balance. So the balance, again, is comprised of the three systems: vision, vestibular, and proprioception. So with computerized posturography, we're able to assess each individual system to see if there is a breakdown. And if there's a breakdown in one or more of the systems, that might be what's contributing to dizziness. And this is just an example report. And then we also do biofeedback assessments. So biofeedback assessments, the primary goal here is to look at how is the body managing the different autonomic functions in the body related to control of blood flow, blood pressure, which, as we said before, can be primary contributors to dizziness for things like concussions, dysautonomia, people with hypertension, things like that. So I'm going to pass it back over to Dr. Chung for a case study.
Okay, so we're going to go review a case study of dizziness. So out of all the different types of dizziness, we're going to review a 44-year-old female with persistent postural perceptual dizziness, or triple PD for short. This was triggered by a event that was fairly common, actually. She had a problem with a lens in her eye requiring a surgical correction. And although that correction was corrected for with the surgery, it all of a sudden triggered significant dizziness. So now she has severe motion sensitivity. She would get migraines. She would have unsteadiness of her balance. Sometimes she'd feel rocking. And it slowly started affecting her cognitive function, that she had difficulty with reading and memory. And simple things like walking down a spiral or staircase would trigger dizziness and imbalance and having to sit down. She couldn't drive. She'd have to take a car or an Uber to an office. And she couldn't go to grocery stores or loud environments. She really enjoyed watching sports and couldn't do that because of all the visual motion and sound. So it wasn't vestibular migraine, it was triple PD. And we came through that through all the diagnostics and history and time course that we reviewed. And then we're now trying to understand, well, why did this event that happened? There was a specific event, kind of remember this in the history of triple PD, that changed her sensory processing between vision and inner ear and body. And but now her brain is having a hard time adapting. So we're doing all the tests to figure out, well, what's going on? Why is the brain holding on to and perseverating these symptoms? And oftentimes it's more than just one thing, which is why it ends up being complicated and not responding in the traditional way to like vestibular rehab and whatnot. And she'd been through all these different kinds of treatments, medications, and things were not working. So when when we did the brain wave analysis, we see here just the raw EEG. We're not going to go through how to interpret this stuff and but the main findings here that I wanted to illustrate are just so you can see a sample of the raw EEGs. On the bottom is the back of the head, and on the top of rows are the front of the head. The thick, spiky stuff that we see in the very top two rows are as some muscle artifacts from muscle tension on the forehead. But within that too, and the 4 to 6 lines down on the top, there's a lot of fast little hyperactivity, and so her brain is very hyper aroused. And this comes from a very particular place between the frontal lobes called the anterior cingulate that allows us to attend and discriminate and focus on what we're thinking or doing or seeing. And when we see all this hyperactivity with what we call these high beta, fast little spiky waves, is that this is often commonly associated with anxiety and hyperarousal. And that can lead to a primary trigger like with migraines or triple PD that we perseverate on what's happening. There's other findings here that we'll see with this is that fast spindling activity I was referring to at the top here related to this hyperarousal and anxiety of what's one of the factors contributing to the perpetual dizziness. And this is a map illustrating looking at the brain from the top down. And each box represents a sensor on that cap we showed with the electro cap. And each box is a sensor and illustrating the slow to fast frequencies left to right. And the takeaway here, I just want to illustrate is that one of the most important things related to EEG and understanding dizziness is this yellow wave here in the middle of these squares or boxes is called an alpha wave. And it's related to visual and auditory processes. And also, when we're talking about this section right here on the left, this is your temporal lobe. It integrates complex visual motion, and everything we see is related to memory, firing into your memory centers so then you can identify what you're looking at, and then things like reading and word finding and things like that. And when it's slower and very asymmetric, this whole section on this left side is not working very well. So vision and memory and reading and language, these whole centers as they fire to combine together are fatigable and too slow. And there's a lot of other red activity here that shows there must be some other inflammatory triggers that happened that are affecting this region of the brain. And so you can get some overlapping triggers with that, in addition to that hyperactivity that we pointed out in the whole front of the brain. So you have these asymmetries and weakness of visual and auditory and vestibular processing in this temporal lobe that controls your heart rate and blood pressure so that you have good orientation. So that's the summary of really what's happening with this image and what we're identifying. And we can see these waveforms are projected or being originated from these deeper structures called the insula, which is in the temporal lobe that controls your autonomic nervous system. Your brain senses and perceives vision and hearing and balance information and controls what your heart rate and blood pressure should be in an appropriate manner. But when there's dysregulation and weakness or fatigability in this system, you get these small visual triggers or sounds that can all of a sudden trigger dizziness and low blood pressure states and all these kind of weird sensations of rocking and moving. Then and they just can be just terrible and affect your orientation and cognition. So this is just an article that shows these little temporal findings that I was pointing out in the yellow peaks, that when we see these kind of slow and sharp spiky waves are non-specific, but they do reflect usually changes in blood flow to those brain regions. They could be a signal of underlying issues related to blood vessels. So we did imaging to look at the blood vessels of the head and neck and clear that as any kind of structural issues with blood flow. But it also can be a sign of irritability as those systems are struggling to fire and integrate information appropriately. So this is another article related to triple PD. If you recall that I mentioned that triple PD is very heterogeneous. There's a lot of different contributing factors. There's even a lot of studies and MRIs looking at structural changes of people with triple PD related to the essential pathways of the brain that lead to weaknesses of that kind of processing with vision and balance systems. But overall, it's really talking about that it's clear that with these brain regions that we can functionally measure with the testing that we do from brain waves and eye movements and balance to then correlate with these kind of articles saying that there's a mismatch between these sensory systems. And now what we need to do is use treatments that can engage each of those systems in a hierarchical fashion, from the brainwave communicating pathways to the sensory processing of the eyes, the ears, and the body, to make sure that the brain can do things and know where they're coming from. So we're going to jump back to talk to Tolentino to talk about some of the personalized neurotherapy and rehabilitation approaches.
Thank you for that. So yeah, so when it comes to treatment, it's very similar to our approach to evaluation. So once we can identify the root cause of the dizziness, then you can take a very targeted approach to treatment, and personalize it. So go to the next slide. So the goal overall is we like to take a three-step approach where we like to stimulate the brain, engage the systems related to those symptoms, and then train the brain and the body in order to overall be stronger and more stable. So the different techniques we choose for treatment have this layered approach to make sure that we are building a strong foundation and then building strength on top of that. So some of the techniques we might use. So these are some of the techniques that we often use in clinic for treatment to personalize. So start with neuromodulation. So neuromodulation can include photobiomodulation, which is like if you've heard of infrared training or infrared laser, for example. This is a way of using infrared light to stimulate cells to produce more energy. So this helps with energy mechanisms in the brain. Or we can use electrical stimulation, essentially neuromodulation. The idea here is to use techniques to help heal those areas of the brain or body that have been identified as being injured, or maybe they're not engaging in the way that they're supposed to. So we want to start by addressing those if there are any injuries. So like for example, in concussion, we can identify in the QEEG that maybe there are structural issues in the brain tissues themselves. So we want to be able to support those tissues and kind of prime them to be able to be more responsive to other types of therapy. So we want to use neuromodulation to kind of address and heal those tissues directly. We also use neuromodulation to help shift symptoms. So we can, if the brain a lot of times can be stuck in a loop, and that can cause symptoms. So we can use neuromodulation to kind of shift the brain out of those states. So we can use that neuromodulation, for example, with migraines. Migraines, a lot of times the brain gets stuck in a pain loop or a dizziness loop. So we can use neuromodulation to interrupt that loop. So then we can use other types of therapy to stabilize. So then we want, after we've stabilized and addressed those injured tissues, we like to use biofeedback to help engage those systems. So re-engaging those systems to come back into normal function. Biofeedback, we can use, for example, EEG biofeedback. So this is also called neurofeedback. So this is basically teaching the brain or the body to learn self-regulation again. So, say, for example, in our past case study, that patient's brain um, kind of lost its normal stabilized function. So here we can get the brain to shift back and then hold that more stable brainwave activity and brainwave pattern to then be more functional and be able to handle the sensory information that's coming in related to vision, related to motion, related to body awareness. And then we use rehab to strengthen those systems. So, for example, if we identify weaknesses in her balance system, in her inner ear system, we can use rehabilitation to target and strengthen those areas. So, really, the idea here is using a comprehensive evaluation approach. And at each level of those things that we're evaluating, we can, if we're identifying weaknesses, we can come in with a very specific targeted treatment to address those individual pieces. So it's very tailored, very specific, and we're getting at the root cause, not just taking a blanket approach. So this just is going over some of the techniques that I discussed in the previous couple slides. So depending on what we find in the evaluation, we may combine, we will always combine some number of these types of therapies, whether that's neuromodulation and neurofeedback. We'll do vision therapy if we're identifying issues with eye movements. We can do vestibular rehab if we're identifying peripheral issues with the inner ear. We can use physical rehabilitation to help strengthen those proprioceptive systems related to awareness of the body in space. We can use biofeedback to train and strengthen the brain tissues themselves to help with better handling of that information. So strengthening the software. And then we use diet and nutrition again to support and give the body and brain the substrates that it needs to function optimally.
Okay. So this is the follow-up of the 44-year-old female with triple PD. Maybe hard to identify what the changes are looking here, just another snippet of the raw data. This is the follow-up QEEG. And if you just recall, one of the main things that I was pointing out is on the left side here. It was actually on both sides, but it was really large on this left side. It was very large yellow and larger dark and red waves here in these two boxes. This one still responded, but not as much yet. But at this point, they were already, I think we did 20 sessions here. We probably did 40 sessions total after the first 20 sessions. Remember, she was very severe and quite disabled with her function, and she was more than 50% improved at this point. And that also, you can see across the board, the temporal regions are much stable. There aren't these very large, weird, slow waves that shouldn't be there. And then when we take a look at a comparison view, again, this is the cap that the person was wearing, looking from the top down. This compares the initial QEG to the follow-up QEG. And basically how it's illustrating the difference between those two studies is that the blue line here is what was previous, the red line is what is current. And another way it illustrates is that anything below this horizontal line in the middle has decreased from the previous. And if it's above the horizontal line, it's increased from the previous. So it's a good sign that all the slow stuff in the dark red and bright red and the yellow that shouldn't have been into these areas are significantly improved across the board. And that's a really good response. So that is really amazing. After she did 2 courses of care, she was basically 98% recovered. She can go to grocery stores, go to games, go out to dinner and noisy restaurants, read and write, and do every single activity in her life and enjoy it. She'd only get occasional lightheadedness or brain fog if she was just very active, like many different activities that normally would have triggered dizziness, and she was tired. She might have a little bit of a day to recover, but was very well managed and is continuing to be much better day in and day out, do all physical activities and exercise. So it was a wonderful success story in collaboration with the concierge clinic in town as well. And we were all very happy and high-fiving each other at the end. So um, that concludes the presentation for today. So I'm going to open it back up to the questions. And this is pre-recorded at the moment, so we're going to add additional questions here if we are missing them from the next recording. But in closing, what's important is that you've identified now or learned that there's a lot of causes of vertigo and dizziness, and we have a comprehensive approach, but also we have refined, streamlined versions depending on what particular symptoms and history you're presenting with. So the best way to get started with us is just to call and schedule a free 15-minute phone consultation with myself or Dr. Tolentino so we could identify what's the best type of evaluation to move forward for the next steps. And so then we can get you on your road to recovery. And also we collaborate with many other providers to help manage you in a comprehensive and holistic way. So you can also follow us on Instagram, Facebook, YouTube. We have other informational videos, and we're always adding more as we go along. So I look forward to meeting any of you, and let's stay in touch. And thank you for attending.